讲座的 title 是 COVID-19 pandemic. It's now 1 year and what's next? 这个讲话内容也许太多了。我看了一下我阅读和收集的文章，在我这个coronavirus folder 里边，我昨天看了一下，有243个 folder 和 subfolder， 有1100多篇文章。看到的文章到处都记不得了，但是讲到数据的时候，还是可以有些印象可以把它找出来，因为我把它分门别类的收藏起来了。但今天的时间不可能都讲到这一年发生的事情，我们简单的回顾一下。So as we call, the pandemic started out in China, probably in the late part of maybe November, December of 2019, and quickly it surfaced and went up to be more than 500 new cases per day in Wuhan. And that's when the city locked itself down on January the 23rd. And as you can tell, within 2 months, the pandemic, local epidemic was pretty much wiped out. And by April, the city was able to open up. What's interesting is I remember WHO publishes a report. It's called the Daily Situation Report. So I extracted the data from the WHO report and plugged into my Excel database. I was watching the epidemic curve very carefully every day. And everybody was talking about when it's going to be the turn of the epidemic curve, 转折点. And what's interesting, I observed the phenomena. Most people talked about this new case curve per day that just kept going up and up despite the lockdown. But very few people were talking about the growth rate of new cases. That is plotted on the y-axis on the right-hand side. I tracked the number of percentage of new cases that's higher than the prior day. What's interesting is within 5 days of the lockdown, on the 23rd, it was locked down. On the 28th, 5 days later, the new case growth peaked. And after that, it dropped rapidly. So without any epidemiology background, I have no clue what that means, but I thought that might predict the real turn of the epidemic curve is going to come. Indeed, 13 days after the lockdown, the cases dropped. And so one thing I learned is not only watch the new cases per day, but also watch the growth rate of new cases. That is actually a good predictor of what might be coming next. So that's what I learned from the Chinese epidemiology curve. And I applied that to what happened to the rest of the world. So I plotted daily new case growth rate, initially very similar for China, the blue line, and for the rest of the world. They were overlapping. At its peak, it's almost 40%, 35 to 40% higher than the previous day. 40% will give you a doubling dates. Every 2 days, your cases will double. But very rapidly, as you can see, the Chinese curve steadily dropped the growth rate, and then the rest of the world kind of gradually trended up. The divergence occurred. And I had a sense that we're probably going to be in trouble outside China. It was a very interesting and intense time to watch the epidemic curve last year between January and February. And on February the 12th, I remember shared some analysis on my WeChat moment, because something interesting happened that day. As the curve dropped, the Chinese new cases dropped from about 3,800 new cases per day to 2,000. But on that day, all of a sudden, they went up to 15,000, a 7.5 times higher increase. And we were all startled initially with thinking, oh my God, this is getting worse again, getting out of hand. But then we read from New York Times and other places, it's a change of definition. Wuhan got a new leadership installed, and they opened up the data, and they described the epidemic as anybody who has clinical diagnosis will be counted. In the epicenter of pandemic, somebody walks like COVID-19, talks like a COVID-19, it's probably what it is. So the conclusion number one was don't panic. It's not really a deterioration of the situation. It's just a change of definition, of case definition. But what's not talked about is what I described here. It gave me a chance to calculate what was missed. If you have 2,000 cases yesterday and 15,000 cases today without real change, that means you missed many cases the day before and or many days before today. That would mean for every new patient you diagnosed, you missed 7.5 cases. So I did a rough calculation on the back of the envelope. That would tell me at that time in Wuhan or in China, there were probably 350,000 infected patients that we didn't know or missed. The comments were all over the place. Oh, that's too much. That's probably underestimation. But one interesting comment came from a good friend and colleague in GI, Dr. Huang in South Puget Sound. He did a calculation based on the epidemiology modeling of University in Hong Kong that said sometime on January the 25th, there were probably 75,000 cases in China. If you calculate by the gross doubling date of 6.2 days, by that February the 12th, you will come very, very close to 350,000 patients in China. And so we used different methodology and we came to the same conclusion. The question is, were we right? Were we close or were we totally wrong? But very interesting, I got an answer from a study just published in Lancet on March the 20th, 8 days ago. So this was from Wuhan. As they show here, in January, the cases shot up. In the middle of February, it peaked and came back down very quickly and disappeared. So the lockdown happened on January 23rd, and the lockdown was lifted on April the 15th, on April the 8th. So right after the lifting of lockdown, meaning there's not any significant new cases, they did a baseline survey by antibody test. They tested 10,000 samples from Wuhan and they tried to determine how many people were infected, knowingly or unknowingly. And then they followed up for 6 months and 7 months. We'll talk about the follow-up later, but let's look at the baseline survey. So the baseline survey, about 10,000 people, is such that about 6.9 of the Wuhan population had antibody against SARS-CoV-2, meaning that they were infected. Some of them were diagnosed, some of them were missed, and a lot of them were missed, apparently. So if you calculate that number, Wuhan is a city with a population of 11 million. So if you multiply 11 million by 6.92%, you will come to 761,000. So our calculation about 300,000, 350,000 a couple of weeks earlier than that was very close, actually quite close to what turned out to be the truth. And this study has something else interesting I want to comment on as well, because they divided up the age group from 0 to 5, every 5 years going up. And what's interesting is we know here is a WHO situation report number 89 in April. As you can tell, most of the people who got infected or symptomatically infected were in the middle of the population pyramid. 50 to 59 is the biggest number. As you go below age 20, most people were not infected, particularly below 10 years old, a fraction, perhaps less than 1% of the adult population. But yet, when you look at the antibody positive rate between 0 and 5 years old, they're not much different between 18 and 44, 6.3 and 5.3 and 6.5%. That means a lot of the young kids were not infected. They just did not have symptoms. Perhaps they could serve as a pool to infect others, perhaps not. But this might have implications for school closing, school shutdown, because when you open up the school, the kids get infected, they can go home and get their parents sick, because they do get infected. It's not like they don't. So this was a very interesting study just published 8 days ago. And that's what happened in China. And let's look at what happened in the world and the US in the past year. So far, as of yesterday, the world has about 126 million cases, and the US has 30 million. And in terms of case per million, meaning how the prevalence is or incidence is, the US is much higher than the rest of the world. Luckily, in Washington State, we're half the rate of the US average, particularly in King County, 39,000 per million, and Snohomish County, 39,000, very close. But in the agriculture counties like Yakima, Spokane, the rate were much higher for a variety of reasons. So this is what happened in US. And what I learned from the US epidemiology curve, something I could not learn from the Chinese, tracking the Chinese number, is not only track the number of new cases per day, the growth rate per day, the positive test rate per day is also very helpful. As you can tell here, I have 3 curves. The top blue line is New York State, New York City, actually. The middle is average US. These are the numbers I compiled from the internet and plotted into Excel myself. And the bottom green line is Washington State. What's wrong with high positive rate? The problem with high positive rate is that, meaning that the healthcare system is overwhelmed. They're not doing enough testing. There are not enough tests to come around. People did not go to the hospital. When they come, they're sick enough. Half of them were positive. So every time you see a positive number like 50%, you know you're missing a lot of diagnoses in a community. You're going to have a lot of cases in incubation period, and the number is going to go up. And as before the summer, the whole New York City US average and Washington State came down below 10%. It was very good, but unfortunately, we had multiple peaks of outbreaks. So what I learned from the epidemiology curve, new cases per day, new case growth rate per day, and the positive rate per day. These are key numbers to watch. So I briefly talked about what happened in the last year, which everyone is aware of. And what's next? I'm not the fortune teller, and I don't have the crystal ball, so I really can't tell you what's going to happen next, but we can review the data. I think there are 3 forces in the in determining what's going to be the outcome. One is human behavior. We know human behavior and government behavior can be predictably unpredictable. Anything can happen. And last year was horribly bad in the US because it's election year, very politically polarized and charged. And so human behavior is very unpredictable. And the viral behavior is also unpredictable because as it replicates or duplicates from one person to another, it mutates. And the mutation may become resistant, or may become more infectious, or may become more fatal. So this is an uncertain factor. And perhaps what's more certain now, by now, is that we do have effective vaccinations. And we have great scientists in the world and who have brought so many vaccinations to the market. That's just incredible. But that is also affected by human behavior. You give them a vaccination, but they may not take it. Or you have a good effective vaccination you give to somebody who is willing to take it, but then the virus mutates, and then it's going to lose effectiveness. So 3 main factors that's going to determine the outcome. And talking about human behavior, perhaps we can learn from history. This is 1918 Spanish flu pandemic. This article was published in the USA Today back in May of 2020. It compared 2 cities that human behavior affected its outcome and mortality rate. I compared Philadelphia and St. Louis. Philadelphia at its peak, death rate was 257 per 100,000 population, as compared to St. Louis, only 58 per 100,000 population. The two cities at that time were comparable in population sizes. What did they do differently? Well, in St. Louis, they closed the public schools, the banned gathering of more than 20 people. They canceled the Liberty Bonds Parade. What is Liberty Bonds Parade? Back in 1918, it was the tail end of World War I. The federal government, Uncle Sam needs money, so it was doing promotions of war bonds. It's called Liberty Bonds. And Philadelphia was very patriotic, and they did not cancel it. And right after that, they had boatloads of people ended up in the hospital. So we know human behavior and government decisions have a huge impact on outcome and mortality rate. Unfortunately, this was a bloody history lesson we didn't learn, and kind of predictably, because history really repeats itself. Well, let's look at other pandemic of the past century, starting from the Spanish flu of 1918. After that, there were 4 additional influenza pandemic. In the beginning, in the first one, it lasted for 2 years, Spanish flu, and then 1957 and 68, only 10 years apart. These 2 pandemic lasted for 3 to 4 years each. It was pretty bad. And of course, as science and technology, medicine improves, the mortality rate dropped. Initially, it was 675,000 in the Spanish flu. The US lost. And the most recent swine flu in 2009, the death was only 12,000. So as we think we're winning the war against pandemics, then we have new kinds of pandemic coming. After the influenza, we got SARS 18 years ago in 2002. It started in southern part of China, Guangdong and Hong Kong. Here is the WHO epidemiology curve. The y-axis shows new cases per day. As you can tell, it picked up in January, and it peaked in February, and it had a second peak in about March and April and May, and then it kind of disappeared, went away miraculously. No vaccinations and no special eradication of animal pool, even though the studies were done, and the source was found to be some bats in cave in Yunnan. That was the source of the virus pool, but never happened again. And we're not so lucky with coronavirus though. The second coronavirus pandemic, epidemic, was MERS, Middle East Respiratory Syndrome, MERS. This happened about 10 years afterwards in 2012, mostly in Middle Eastern countries. And then initially not bad. In 2014, 2 years later, there was a spike in Saudi Arabia. In 2015, the red was in South Korea. What's interesting is we don't talk much about MERS, but MERS never disappeared like SARS. As you can tell here from the European CDC, as of January to March this year, there were 5 cases reported. Good thing is they were all primary cases, meaning that they were not human-to-human transmissions. They got it from nowhere, or they got it from camels, and did not pass it on secondarily to another person. But this disease tells us coronavirus can become a seasonal perennial disease, may not reach the pandemic level, but it may persist. So we really need something in the long run, like vaccination, to hold it down. Well, talking about vaccination, here is a summary by WHO as of March 16th. They call it Landscape of Vaccine Development. So far, there are a total of about 260 vaccines in development. 82 of them are in clinical trials or in clinical use, and 182 are in basic science research level. They fall into different categories. You can make the antigen by protein subunits like recombinant protein. You can use viral vector like the AstraZeneca, Johnson & Johnson, and some the Russian Sputnik vaccine. They all use adenovirus, non-replicating adenovirus as the vector to carry DNA into the body, and the body, human body, will make the antigen or the vaccination themselves. And then DNA, the DNA will use plasmid DNA to carry into the human body for expression. There's nothing like that on the market yet. And the inactivated virus, which has been used widely now by 2 Chinese pharmaceutical vaccine companies. And then, of course, in the US, we have enjoyed the newest technology of mRNA vaccines from Moderna and from Pfizer, and then many different technologies. As far as how many doses goes, 2/3 of the circle of the pie uses 2 doses. The second dose may be given 14 days later, 21 days later, or 1 month, 28 days later. Very few, 1% will give 3 doses, and about 15% will give only 1 dose, like the Johnson & Johnson, and other vaccines have been undecided, depending on their clinical trial, how many doses may be needed. So for most part, we're probably going to be seeing just mostly 1 dose or 2 dose regimens. So far, as of February the 11th, according to BBC, the Pfizer vaccine has the biggest market reach, about 57%, AstraZeneca number 2, and Moderna number 3, and then the Chinese vaccines number 4 to come after, and then Russian and India. As of March the 17th, China has produced the most number of vaccine doses, 169 million, followed by US 136 million, and the EU. But in the future, perhaps down the road, in the next year or so, US is projected to be the highest producer of vaccine numbers, about 4.7 billion per year, and China will be 1.9 billion. So looks like there will be plenty of vaccines produced down the pipeline by many different manufacturers. So we're having all these vaccines coming to the market. How is vaccination implementation been going? Worldwide, only about 1.5% as of yesterday have been fully vaccinated. In the US, 14%, about 15%. In Washington state, 15.7%. Even though in the US, 136 million doses were given, but only about 15,000 were fully vaccinated, because you need to complete 2 doses to be counted. So some of those doses were given to the same person. If you rank the number of countries that have most successful vaccination rates, in major countries, Israel tops the list, followed by United Arab, and US 15% is actually high up there. So even though our number of cases and death rates have been very high, but looks like our vaccination rate is going to be quite successful. Well, let's go through the clinical trial data briefly for each one of the major vaccines. This one was published in the New England Journal of Medicine on December the 10th. This is the Pfizer data, Pfizer vaccine. What it shows is overall, the Pfizer vaccine is about 95% effective. Efficacy is about 95%. The sample size of placebo, 18,000, vaccination arm is 18,000, total of 36,000 trial sample size. So this is a good sample size of different age groups. As you can see here, it's effective across age groups, and particularly effective for the elderly 75 and above. What's interesting is often commented about this Pfizer vaccine is in a minority group. It's not as good as African American or white. So there were concerns about if this is not going to be very good as compared to Moderna for us Asians. And there was actually a LA Times article a couple months ago talking about this possibility and generated some anxiety in the Asian population. But if you look at the trial data, the sample size of Asian patients were quite small. One case is going to make a huge difference in the final calculation number. So I really don't know how much to make out of it, even though it was talked about. My suspicion is they're probably equally good for the Asian population. The next trial data is Moderna mRNA vaccine, and it was published in the New England Journal of Medicine again on December the 30th, so a couple of weeks after the Pfizer vaccine data. That's why Pfizer vaccine was approved first and the Moderna second. What's interesting here is the Moderna data shows age 65 and above, the vaccination efficacy seems to be lower than younger population. So this is different compared to the Pfizer data. So does it mean for age 65 and above, you should get a Pfizer, and the younger, it doesn't matter, either one is fine? It's hard to know because this is not apple to apple comparison. They're not in one clinical trial. The population is different. The sample size here is a little bit smaller compared to the Pfizer trial. Each arm has 14,000, so total of 28,000 instead of 36,000 trial sample size. And what's interesting here is the Pfizer data shows perhaps in Asian population, it's less effective. Here, community of color, including Asian, the rate of protection is actually higher. Again, it's difficult to know. My suspicion is they're probably equally good. Now, this is the third vaccine approved in the US. That's from Johnson & Johnson, which has not yet published in a peer-reviewed journal of its phase 3 clinical trials. I found the data from WHO documentation. They have some detailed information there. What's interesting is overall in the United States, the Johnson & Johnson vaccine success rate of efficacy is 72%. So sounds lower than the Pfizer and Moderna vaccination and data. But one needs to take into consideration three things. One, the Johnson & Johnson vaccine is only giving one dose. So what if it gives 2 doses? Is it going to be just as good? That's one. Two, the Johnson & Johnson trial happened after the major outbursts in the fall. So there were much higher risk of getting infection as compared to the early days when the other 2 trials were given. So you would imagine this data would be having a lower protection rate because you're in a harsher environment. And 3, this included some other countries, Brazil and South Africa, and in South Africa in particular has this variant that's very tough. And many other vaccines have showed significantly lower protection rate, and yet it's holding pretty well. For South African strain, it's 64% vaccination efficacy. So at this point, it's too early to tell if Johnson & Johnson vaccine is any inferior compared to the other 2, and perhaps we know it's actually not bad for the South African strain. The last one I want to show, there are many other data, including Russian. I'm not going to go through anymore, but I want to talk about the Oxford AstraZeneca vaccine because this vaccine has applied for FDA approval and it's becoming quite controversial. Recently in Europe and some other countries, including Canada, I believe, it was stopped for a while because it was thought it was causing clots and death, but that didn't turn out to be perhaps that bad. So the usage has resumed. The whole process about AstraZeneca data is that this is a adenovirus vector carried DNA vaccine. When it conducted its clinical trials, you see here LD and SD. What does that mean? LD is low dose, SD is standard dose. Even though the clinical trials were designed to give 2 standard doses, somehow somebody made a mistake, gave only half the dose, a lower dose in the first shot to some people. And so some people got 2 standard doses, some people got low dose and standard dose. When they look at the data, what's ironic and interesting is that the people who got the lower dose and the standard dose had a better protection. Vaccine efficacy was 90% as compared to standard dose 60%, 30% lower. How could it be? And is this just a small sample size error? No one really knows. But that really confused the data analysis. So this poor vaccine has many dramas and is still struggling to get its approval in the US. And there are some other issues I would show you with this vaccine. Here's an article summary. I included here, it's too small. I'm not gonna go through this. Pretty much summarize all the vaccines on the marketplace. I included this to the WeChat chat room, so you should be able to review this on the PDF file. So that was clinical trials. It shows efficacy of mRNA vaccine, about 95% overall success rate. The Johnson & Johnson success rate is about 70-some%. The Oxford AstraZeneca data is either 60% or 90%, depending on which dose you used. But what about the real data, real life usage? Aftermarket data analysis is just as important. Fortunately, in the past week or two, New England Journal of Medicine published quite a few studies showing the efficacy in real life usage at a number of medical centers. I'm just showing here is University of Texas Southwestern Medical Center. As you can see here, people who were not vaccinated had a much higher rate of infection as compared to partially vaccinated, meaning only getting 1 dose, or fully vaccinated. And maybe we can mute that speaker. So I'm not going to show you the UCLA and UCSD data, also published in the New England Journal of Medicine, with similar reduction of infection risk. So the next question regarding the vaccination is natural infection as good as vaccination? If somebody got COVID-19 already, and do they still need to be vaccinated? If so, how many doses should they receive? This is quite an interesting topic. If you look at the basic science study, this one was published last year. It talked about how smart this virus is. Its job is to invade into the human body. Its intention is not to induce any immune response. So it has immune evading mechanism. What's the immune evasion mechanism? The receptor binding domain, which is the critical site vaccinations are targeting in a spike protein, is normally lying down. It's hidden. So it's folded. It's not exposed. The immune system cannot identify the antigen epitope. And only when it's ready to bind and invade, it will open up, standing up for receptor binding. So perhaps the antigen presentation of natural virus is not very good because this virus is very smart. As a result, maybe natural infections don't generate lasting protective antibodies. So that was, in theory, natural infection perhaps is not as good as vaccinations, where you optimize the antigen epitope presentation and you get better immune response. So is that really true? Well, here is real life data, which was just published. Everything I presented here, most of these slides I presented here were published this month. So this was published on March the 17th, about 10 days ago, in Lancet from Denmark. So what they did is they had something very similar to what happened in Wuhan. They would PCR test everyone in the city. So they have 50,000 people tested at different times. And then they identify them, who were positive, who were negative, and then follow them up 6 months, 7 months later and see who's gonna get infection. People who already had positive PCR a few months ago, or they're gonna get disease again. So they calculated the protection rate, overall protection rate by natural infection, 78.8%. Wow, that's as good as most vaccination success rate. So in real life, natural infection seems to be quite good. There's not much difference between female and male gender, but there's one difference. For most age groups, it's about 80%, but for people 65 and above, the protective rate was only 47%. So perhaps those who were 65 and above who got the disease should really need to go for the vaccination because the protection is not adequate. Well, so this is in human body in vivo population study, which is very good. But if you go back to the Wuhan study, which we talked about, they checked the antibody in April, they followed in June, they followed in December, and see how long the antibody will last. So at baseline, neutralizing antibody, you can have antibody, but if you're not neutralizing the virus, they're not considered protective. So neutralizing antibodies in those people who had any antibody detected was only about 39% at baseline. They followed in June, about the same. They followed in December, about the same. So one conclusion out of this study is that the antibody generated against the virus after natural infection is probably as good as for the first 6 to 7 months. After that, we don't have data. This will give us implication that how long the vaccination is going to last, at least 6 months. After that, we don't know. We're gonna keep following. But that's one comment I wanted to make, is how long they last. The second comment I wanted to make is, did you notice the difference in human study? The protection after infection is about 80%, but yet in vitro study, neutralizing antibody is only 40%. How could that be true if you only 40% of people have protecting antibody, and yet somehow they protected 80% of these people who had infection? Well, perhaps the antibody is not there, but the immune response, the memory of the immune response is there. And as soon as you get exposed to the virus, you're going to mount a much quicker and stronger immune response. So perhaps the in vitro study measuring neutralizing antibody does not necessarily reflect the protection you get. Plus, their T-cell immune system that's not reflected here by antibody measurements. So to answer the question of immune memory, is it true if you had been exposed to the virus, you got infected, you get the second dose virus, you're going to get a quicker response? Very, very true. So this, again, was published on March the 10th in the New England Journal of Medicine. So they gave one dose vaccination to people who were never infected in the blue bars, and to people who were infected and had a pre-existing antibody. So between 0 to 4 days after the injection, the antibody titer between the two groups were not much different. But by 1 week, 5 to 8 days, the people who never had infection, never had antibody, remained very minimal, barely changed. But in the people who had a pre-existing infection and antibody, the antibody surged very rapidly. So from here to here, you think, oh, just a few lines increase, that's not much. But if you pay attention to the y-axis, there are log bases, 10 to the second, 10 to the third, 10 to the fourth. So 2-line difference is hundredfold different. So there's dramatic difference. It is true. If you were infected before, you see the virus again, you're going to mount immune response much quicker and much stronger. And some people are proposing perhaps for that reason, those who had infection before may just need 1 dose of vaccination, maybe not 2 doses. But that's controversial. I think at this point, CDC and Dr. Fauci recommends 2 doses for everyone, unless you're getting the Johnson & Johnson vaccine. Now we have the vaccination, and but yet the virus is mutating. All these vaccinations going to be good, or good for how long? Those are huge questions that remain unanswered. The first mutation that came to the scientific community was this thing called G614, D614G, D614G mutation. What does that mean? It means in a spike protein of the virus at amino acid residue 614, the amino acid residue was changed from D, aspartic acid, to G, glycine. So that's the mutation. And when this mutation happened in Europe, particularly in Italy last year, sometime in February, it became recognized that it's so much more infectious. Transmission was far more efficient and became dominant. By the end of May, pretty much the whole world infection was taken over by this viral strain variant. But no one is worried about it for now, because all the vaccination clinical trials were done when this viral strain was dominant already. So we know the current data applies to this variant. So that's why, even though this is a dominant variant, no one's talking about it anymore. We're talking about some new strains. Here is the WHO summary of the 3 new strains that are of concern. One is the B117, which originated from UK last September. And one is the South African strain. It's the B1351, which is the tough one. It has all kinds of resistance. And then the Brazilian strain. These are the 3 strains. So let's look at the literature and see how these strains will impact our immune response and antibody protection. So this is a basic science study, in vitro study using lab-generated monoclonal antibody or post-infectious polyclonal antibody to see when the spike protein mutates, can you neutralize it? What it found is a spike-specific monoclonal antibody neutralization is reduced dramatically. So when you use monoclonal antibody to fight the virus when it's mutated, it pretty much lost its effectiveness. So this has huge clinical implications, because in clinical practice, we use the Regeneron monoclonal antibodies for early intervention, early treatment. If you run into a mutated strain, you're not going to be very effective. But on the other hand, post-infection human antibody, which is polyclonal antibody, still works quite well. Why? If your monoclonal antibody, which is site-specific, say, is raised against the head of the virus, the head is mutated, it's not going to work anymore. But if you got polyclonal antibody, it's going to attack the virus to the legs, to the heart, to the kidney and liver. So if you can't get your head, I can get your kidney, your heart, I can still get you. So that's the advantage of polyclonal antibody. Well, let's look at the Pfizer data. So when these mutants came, you really cannot run another 40,000 population clinical trial anymore. It's going to be expensive and time consuming. And what do? You do in vitro study. What you do is you draw the blood out of people who received your vaccination. So you have vaccine generated antibody, and you use lab virus to see if you can neutralize the virus. They try different strains, and then again, it's the South African variant. The neutralization success rate drops to some degree. Still, about the detection rate, still reasonably good, but there's a noticeable drop. And here's the Moderna data. The concept that's the same. You draw blood, getting the polyclonal antibody out of vaccinated people, and you do even in vitro study. And again, it's the South African strain that has a lower rate of neutralization. Their calculation is a reduction by the factor of 6.4. Dr. Fauci has written 2 editorials in the past couple of weeks published in JAMA. His argument is, yes, there's a drop of 5 to 6-fold titer of effectiveness, but the vaccines has generated so much antibody, such a high titer, even if you drop by 5 to 6-fold, you're still good enough, which is probably true. And so this is a newer article in the New England Journal of Medicine from 4 days ago that summarizes all these variants, the UK variant, the Brazil, and the South Africa variants, and listed all these vaccines and show how its effectiveness might be dropping. So for the Johnson & Johnson, there's no data for these strains, but for the South African strain, it's still pretty good, as we showed earlier, about 67%. The Pfizer vaccine, for the UK strain, it drops by 2-fold. For the Brazil strain, it drops by 6.7-fold. And for the South Africa strain, it drops by about 6.5-fold. Not too bad. Like Dr. Fauci says, still probably be very good. But Moderna is very close. And the Russian Sputnik vaccine has no data. Here comes the AstraZeneca. So the AstraZeneca is actually a human study, which I will show you next. It shows in front of the South African strain, the efficacy is dropped by more than 86-fold to almost complete immune escape. So it became totally useless. And the Chinese Sinopharm one was decreased only by 1.6-fold. We don't see the data. So this AstraZeneca Oxford vaccine seems to be somewhat problematic, not only in its clinical trials, data gathering, and also against the South Africa strain. It does not seem to be very good. Here's the human data that was published in the New England Journal of Medicine on March the 16th. And all the previous ones, remember, they were in vitro study. You draw the blood and you do titration study, neutralization study outside the patient. Here is human study, very powerful. What you can see is you cannot see much of a difference between the vaccine and placebo for a mild to moderate disease. So the AstraZeneca vaccine seems to be a almost total failure in front of the South African strain. That was the final conclusion. All right, so I wanted to conclude my talk by showing you this triangular shape of viral mutation, human government behavior, and vaccines. I really cannot conclude about the future, but I can only tell you pandemics will always go away, no matter what. Even if you do nothing, it's going to go away. For respiratory pandemics, usually last for 1 to 4 years. Eventually, enough people will develop herd immunity, enough people will die, the weaker will die, and the ones who survive will have the immunity and move on for another decade or so before the next pandemic will happen. But obviously, if we take the natural herd immunity approach, which was proposed by the British in the beginning of the pandemic last year, there will be tons of human life lost. So we have to do something, which is vaccination by the scientists and the population public cooperation and government decision-making. And of course, the virus will continue to mutate and we cannot tell what's coming. Because today is a dental association talk, so I thought I would show you this slide. When I read this UK clinical trial confirms that nitric oxide nasal spray was effective 95% in 24 hours to reduce the viral load and 99% reduction of viral load by 72%. I thought, wow, this is great. The dentists will love it. Is this laughing gas? But when I look at the chemistry, which I didn't know, and now I know after I did some study, so the laughing gas is nitrous oxide, N2O1. And what they used here is nitric oxide or nitrogen monoxide, which is a free radical. That's why it has antiviral and antimicrobial effect. And then there's nitrogen dioxide or nitrogen oxide, which is used in fertilizer. And the laughing gas used by you dentists is separate and it's different. It's nitrous oxide. Well, this is just a side note. Thank you so much for inviting me.